Matt, for your signal.
Okay.
Are you ready?
And that looks like when I'm talking, it's picking up pretty much just fine.
Yeah, I think it's going great. And you should be happy, Vogue.
Do you want those two to wear headphones?
No, not until he goes and joins the group. Do we need to?
There you go.
What happened? Am I live?
Get live.
Hi. I don't know if you guys can hear me. My name is Ashish Jha, and if you took PH555X, I assume you're pretty sick of me by now. But I wanted to take a moment today to thank all of you guys for taking the course. Thank you for all the feedback that you've given. It's been a really terrific experience for us to teach it. It's very clear to us that we could do a lot of it better next year, and we're going to take your feedback. And if you have taken the course and haven't had a chance to give us feedback yet, please go ahead and take some time and do that, because in the spirit of quality improvement, these things only get better when people who experience it provide their perspectives. So if we just finished week 8, we heard from Julio Frank, Ed Kelly about the importance of quality. And the kind of one-line summary of the course, as I have thought about it, is, access to healthcare is really important, but access is not enough, right? And you really have to focus on what are we giving people access to. And my hope is that what you got from the course was some detailed information about how we might think about what we give people access to and how to make that better. The purpose of this Google Unhangout, and I have never done an Unhangout before. I've never even done a Google Hangout before, so this is all new to us, is to talk about Ebola as one potential lens through which to look at health systems. And I want to spend 5-7 minutes talking about how I've been thinking about Ebola, what's been happening in West Africa, what's been happening in the US, what that teaches us about health systems and healthcare delivery and when it works and when it doesn't, what its implications are, and how you might look at the Ebola outbreak from the framework of quality and help understand some of the numbers and some of the data that are out there. And so if you think about the Ebola outbreak, in my mind, there are two broadly speaking, couple of places where the Ebola outbreak has been really meaningful. 3, actually, you could argue. One is certainly in West Africa, right? Sierra Leone, Guinea, Liberia. Another is the US. Interestingly enough, the US has had 9 cases. Several of them diagnosed here, 2 of them transmitted here, several of them people transported from West Africa with the diagnosis in hand. And then there's also Nigeria that suffered an outbreak, and then eventually it was able to be contained. And looking at these 3 countries, or 3 areas, not these 3 countries, these 3 areas, teaches us a lot about why the outbreak has been so different in different places. And one statistic to think about is, so the numbers from West Africa around Ebola are still changing, but the kind of ballpark notion is that there have been about 14,000 cases in West Africa with about a 70% mortality rate, 70%. In the US, 9 cases, 1 death. And believe it or not, even though 9 cases, 1 death is a very small number, that is a statistically significant rate difference, 11% in the US versus 70% in West Africa. And now you're looking at me and thinking, well, that's not that interesting. Of course, West Africa's got far fewer resources, which is clearly true. But it is worth thinking a little bit about why the outcomes have been so different. And I've been talking to colleagues who've been in Liberia, who've been also working on these issues in the US. And their argument is that in America, the mortality rate for Ebola should be 0. If we get our act together, our mortality rate should be 0. And actually, the only person who's died in the US is a gentleman, Mr. Duncan, who was misdiagnosed, classic safety error, and then not treated effectively even when he came back. And so it was a quality failure that led to the 1 death we've had. The other 8 people who've been treated for Ebola in the US have all survived. It says that if you get your act together, if you have a healthcare delivery system that works well, you should be able to get to zero. And I am not claiming, given the paucity of the resources, the challenges of the healthcare delivery systems in West Africa, that they could get to zero. But I am arguing that every death of Ebola in West Africa in the ideal world is preventable. And that's frustrating if you think about the human toll of Ebola in West Africa. It's frustrating, it's disappointing, it's outrageous. There's so many words you can use. And the other point I want to make on that, I'm going to come back to a little bit about why the difference between the US and West Africa, because it's not just about resources, though it is partly about resources. The other point is it's when we've looked at some data from West Africa, the Ebola treatment units that are up and running, some data from there suggests that there are wide variations in outcomes among Ebola treatment units, even in West Africa, even in Liberia, for instance, with some places with mortality rates of 90% and other places with mortality rate of 30%. And that huge gap is a quality problem. It's not just an access problem. Okay, so let me spend a minute talking about why the mortality rate has been so much lower in America. And I really do think this is important because it tells us something about when health systems work, what does that look like? Why do they do it? So why has mortality been so much lower here? Part of it is, in general, we've gotten people into the healthcare delivery system much faster, right? The 2 nurses in Dallas who got the infection from Mr. Duncan, both of them were identified early, both of them were treated early. Second, if you think about Dr. Spencer, the physician in New York who picked it up in his work for Doctors Without Borders, again, he got identified early, got treatment started earlier. So getting people into the healthcare system early is really important. Now, people classically think of that as an access problem. I don't. It's a little bit about access. It's also about quality. Because part of the reason why people are hesitant to go to the healthcare system in West Africa, in India, in lots of places, is they don't trust and have faith in the healthcare system. And so notions around patient experience, building trust in the healthcare delivery system, that's not an access issue. That's a classic quality issue. And that has been a major hindrance in West Africa in terms of being able to deliver high quality healthcare. And I think has been a major contributor to the high mortality rate that you see there. So again, access, yes, money, yes, but focusing on quality, focusing on experience, focusing on treating people with dignity and respect actually has a big payoff in terms of getting people to come in earlier. If you get in earlier, you get treated better. If you get treated better, you're more likely to survive. And that creates a virtuous cycle where more people are then willing to come in earlier. And I think that has happened in the US better than it has in many places in West Africa. Second is around effectiveness of treatments, right? So in the US, we've had much lower mortality rates because we've been able to give people fluids effectively. We've been able to monitor their laboratory tests more effectively. Yeah, some of that is clearly about resources, but it's also about training staff, having very clear protocols in the places that have been taking care of Ebola patients. Again, there's one place where the mortality rate is 100%, 1 out of 1, that's the Dallas hospital. And it's very clear from the way they managed that case that there were a series of mistakes that really are about quality and patient safety. And it led to, can I tell you directly that those mistakes caused the patient's death? I don't know that. But what I can say is it clearly contributed. It didn't help the situation at all. So I think that's important. I do think a third point I want to just make, even though it doesn't quite fit in the quality framework in exactly the same way, but it's worth making. I think part of the reason we've had much lower mortality rates in the US is we're trying a whole bunch of experimental therapies. I can't promise you that I know those therapies work, but the best evidence that I've seen suggests, even with these small sample sizes, that those treatments are making the difference. The antiviral drugs, the transfusions, and of course, a big part of the question is, to the extent that this epidemic continues to rage in West Africa, how do we begin to scale up and start getting treatments to those ETUs, Ebola treatment units in West Africa, so they can start deploying some of these antiviral drugs, some of these other things that are so important. So just taking 2 case examples, again, the US versus West Africa, and thinking about it from a quality lens, issues around safety, issues around effectiveness, getting the right treatments to people, issues around patient-centeredness, treating people with respect. None of that is meant to argue that the big 800-pound gorilla in the room here, which is the dramatically different level of resources that West Africa has compared to what the US has, doesn't matter. Of course it matters. It feeds into those issues. But I think if we only focus on resources, we miss the bigger picture, which is about delivery of safe, effective, patient-centered healthcare that I think has made such a big difference in terms of treatment of Ebola and therefore the outcomes of Ebola in the US compared to West Africa. Okay, so those are a couple of big picture points. I think I'm looking at my group here, by the way, the folks from the PH55X team. I don't know if there's other stuff that they'd like me to tackle before we break out into groups. I'm going to take 1 second and get some feedback. Yes? The infection rate of staff. It's actually an interesting question, right? So if you look at Ebola infection rates in the US, compared to West Africa, there's a bunch of different ways of thinking about the data. Two important points, I think. One is in Dallas, at the Dallas hospital, 1 patient led to 2 new infections. Imagine if the numbers were that bad in West Africa, right? They have taken care of, depending on which numbers you look at, 10,000 patients. And our best estimate is that 400 to 500 healthcare workers have been infected. So the healthcare infection rate in West Africa is dramatically better than what you saw in 1 US hospital. It's interesting. If you think about resources, if you think about training, I actually think the gold standard of the organization that has done this so incredibly well is MSF, Médecins Sans Frontières, Doctors Without Borders. They have, but how do they do it? Do they have more resources than the hospital in Dallas? No, of course not. They have done it by focusing and making this a priority. One of the things I hope you got from for those of you who took the course, listening to T.S. Ravi Kumar from India, listening to people like Ed Kelly and Julio and Maureen Bisignano, is so much of quality is about prioritization. It's about making something a focus, not assuming that if you've got the resources, you're just going to get it done right. That doesn't work in any other part of our lives. It doesn't work in healthcare. It really is about focus on priorities. And MSF, I would argue, has been a more effective organization, has done a better job on preventing infections than certainly the 1 hospital in Dallas did. Now, the other good news for the US side is that all the other hospitals in the US have made it a priority. Infection control, preventing healthcare workers from getting infected. And our rate among the other patients is 0. Now, again, small sample sizes. I don't want to get into too many direct comparisons because it is hard. But it's worth understanding 1 patient led to 2 new infections in Dallas. Thank God we don't have numbers that bad in West Africa. All right, I think we're getting to a point where we're going to break off into groups and have discussions around these issues. We have about 45, 50 people who have joined us for this Unhangout. And so I think what happens next, Stephen, in terms of how the process goes?
We're just going to hang up on you. And
okay, I'm going to get hung up on.
in their groups, and everyone's going to go to the left-hand side of the page, and they're going to join a group.
Okay.
And that's just by hitting the join button.
Got it. So I hope
available now.
So I hope everybody got that. You can all join a group, pick a group, and
you can actually.
And then I will join one of the groups as well. I'm going to pick randomly. I haven't yet decided which one. And then we'll see where the discussion goes, and then we'll come back together near the end of the hour and hear back about what people said and what people discussed, and then go from there.
Right.
Okay, so I'm gonna hang up on me, but then I'll come right back at the end of the hour. Thank you, guys.